Now, my great pleasure is to say that I had the opportunity to meet Sherita about 12 years ago through a mutual friend. And at that point, we were both at similar sort of mid-career levels where we were dealing with remarkable similar situations in the diabetes research field, trying to get our, well, we all know the challenges that point where you get up to where you're trying to get your grants refunded, where you're moving in different directions and trying to keep it all balanced. And at that point, I was just amazed at how many, at that point and beyond, I was amazed at how many balls Sherita literally was able to keep in the air. Now, many of you may know her from different spheres because she occupies many spheres. So there are some of you who will know that Sherita has made very important contributions in epidemiology in different areas, probably most notably with regards to the relationship between depression and diabetes. So it's contributed many important papers. Many of you might remember the landmark JAMA paper, I believe it was 2008, demonstrating that there was a bidirectional relationship between diabetes and depression. So that was quite revolutionary. She also contributed to exploring relationships among sex hormones and insulin resistance in postmenopausal women. But increasingly, Sherita was becoming nationally renowned as an expert in health disparities related to diabetes. At the same time, I found it rather remarkable that Sherita was involved in some large and important clinical trials, for example, being the Hopkins lead for the DPPOS. And she, at the same time, or more or less, at the same time, was also leading the inpatient diabetes service at Hopkins. So at some moment when Sherita might have been expressing some level of concern about the future, I said to her, Sherita, I know you're going to be dean one day. And I'm holding to that, actually, because if you could see the meteoric rise that Sherita has had over the last few years, I don't think there's really anything left than being the dean. So Sherita then went on to become the executive vice chair of medicine at Hopkins in 2015. That same year, I believe it was the same year that you had the beautiful ceremony receiving the McCormick Chair, which was a very exciting event. I was happy to attend. And then went on then in 2019 to take on a very important and very exciting role, which is the Vice President and Chief Diversity Officer at Hopkins, and is therefore positioned to make very real and substantive changes. So after all this, I want Sherita to get a chance to speak. So let me just say, it's just a delight to have you with us today.
Thank you, Meredith, for that wonderful introduction. And I'm so excited to see so many of my friends joining from different walks. And I only wish we were in New York in person, but hopefully at another time I'll get a chance to come back up. So I'm going to share my screen and make sure I'm sharing the right one. So what I'm going to talk to you about today, if I can get the slides to come up. Hold on for 1 second. Let me stop sharing and try that again. Let me just share again. Okay, I think it's almost showing up here. I'm going to just open my slides one more time. Just give me 1 second. So this is all of the, for those of you who know me from my stress researcher perspective, I feel like all of these things that we're having to do in virtual spaces is completely like testing our resolve, if you will. So let me just get this up correctly and then we will get started. And Meredith, I wish your mother well in her recovery. I will say that Meredith and I have also been journeying on the elder care pathway most recently. So the parallels continue, if you will, in many ways. So let me, Okay, so now we're going to try the share screen again. Okay, so everyone's seeing that now, or are we
Yes.
good?
got
Okay,
it.
terrific. Okay, so so what I'm going to talk about today is a little different than I think the last time I spoke to the Diabetes Center at Einstein. I was talking mostly about hormonal risk factors for diabetes and cardiovascular disease, and I am an endocrinologist, and I completely love hormones. But I will say that my work in the last couple of years has begun to help me sort of step back and look at disparities in diabetes from a broader perspective, and that's what I want to share with you. And so the title of my talk is Understanding the Historical Context of Diabetes Health Disparities to Catalyze Present-Day Solutions. I hope to end with what it is that we can do so we can sort of leave feeling uplifted. So just in terms of disclosures, just sharing that I serve on 2 health equity advisory boards, one for Medtronic Incorporated, another for Abbott. I'm not going to discuss any unlabeled, unapproved uses in this presentation. So the objectives are to articulate 2 medical and scientific contributors to diabetes disparities, to articulate 2 social conditions contributing to diabetes disparities, and to articulate interventions to reduce race, ethnic health, and healthcare disparities in diabetes with the aim of achieving health equity. So if I think about the field of health disparities, I actually acknowledge that many things have evolved in this arena in my own lifetime. And so I realize this is a risky slide to show because you could actually calculate my age, but I show this because I was born 2 weeks to the day before Martin Luther King Jr. was assassinated. So I was born on March 21st, 1968. Martin Luther King Jr. was assassinated on April 4th, 1968. And I was born in Washington, D.C. And this was sort of how H Street in Washington, D.C. looked prior to the riots that ensued after his assassination. This was only about maybe a mile from my grandmother's house where I spent many years. This is how 8th Street looked afterwards. And I will say that it was not until about 2012 that 8th Street was restored to its prior form. And then in 1972, when I was just 4 years old, the results of the Tuskegee syphilis experiment became public. So this was a study that where African-American men in the South in Tuskegee, Alabama, who had syphilis were basically withheld treatment. So at the time, penicillin was a known treatment for syphilis, and that treatment was intentionally withheld for 40 years to observe the natural history of syphilis. But what was unfortunate about that is that not only impacted those men's health, but the health of their offspring, their spouses, and others around them. So I just point this out to say that it was not until 1972 that this was uncovered, and we began to think about how we change research practices to protect vulnerable communities. So in the early 80s was the establishment of a task force on Black and minority health under the then Secretary of Health and Human Services, Margaret Heckler, who served in the Reagan administration. And she commissioned that report based on a foundational report published in earlier by the Association of Minority Health Professions Schools called the Study Blacks in the Health Professions in the 1980s, a National Crisis and Time for Action. And the co-authors of that report were Dr. Lewis Sullivan, who was then the Dean and President of Morehouse School of Medicine, Dr. David Satcher, the President of Meharry Medical College. Both of them went on to be Surgeon Generals of the US in different administrations. Dr. Walter Bowie, who was the Dean of the Tuskegee University, and Dr. M. Alfred Haynes, the Dean of the Charles Drew University of Medicine and Sciences. And their report pointed out the shortage of minorities in the health professions and health disparities among Blacks. And this was foundational to the Heckler report. So the Heckler report, which was published in 1985, really tried to quantify the disparities and noted that health disparities accounted for 60,000 excess deaths each year. The 6 causes of death that accounted for more than 80% of the mortality among Black and other minority populations. I mean, you can see diabetes was one of those top 6 at the time, 33% higher in Black compared to the white population back then. And what the report did is it outlined recommendations to reduce health disparities, the need to improve data collection among Hispanic, Asian Americans, and American Indian and Alaska Natives. So again, not just quantifying health disparities in the Black populations, but in other minoritized populations as well. So there were several outcomes of the Heckler report. So in 1986, there was the establishment of the Health and Human Services Office of Minority Health, whose first leader was Dr. Herbert Nickens. And then there were other outcomes following the Heckler report. So there was pivotal legislation, funding, policies, research, and initiatives focused on minority health and health equity. There was the establishment of the NIH Office of Minority Health. There was also the establishment of the Centers for Disease Control and Prevention, as well as the Health Resource and Services Administration. There was a push toward more inclusive data collection techniques, and then the establishment of institutions, centers, commissions, as well as state and local minority health offices across the country. But despite all of that, in 2003, there was a publication of this very famous Institute of Medicine report called Unequal Treatment. And what this report did was, instead of just sort of summarizing or quantifying disparities, tried to look at what were some of the root causes. So this report examined health system, provider, and patient factors contributing to disparities, and found that ethnic minorities had less access to preventive care, treatment, and surgery. That resulted in delayed diagnosis and advanced disease at presentation. And there was a persistence of race and ethnic disparities in health and healthcare, despite what we had learned since the Heckler report. So this is my favorite quote of Dr. Martin Luther King Jr.'s: "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." And again, as we think about patients who come into our healthcare system, this is when people are the most vulnerable, and there should be the most compassion and equity, but that has not always happened. So one of the questions is, how did we get here? What's the historical, medical, and scientific context of health disparities? And what has been our role as a medical and scientific community in defining differences and levels of humanity that have contributed to disparities? So one of the first things that happened during the slavery era is that many medical advances were made at the expense of slaves, and particularly female slaves. So this is a very famous painting of Dr. J. Marion Sims, who's considered the father of modern day gynecologic surgery. He invented the speculum, and he experimented and repeatedly performed his gynecologic procedures on slave women with not only without their consent, but without general anesthesia. And this was at a time where ether was actually available as anesthesia, so this was an intentional withholding. And he was rewarded with international acclaim and presidency of the American Medical Association in the early 1900s. So again, no one seemed to think that this was problematic. And this kind of experimentation continued into the post-Civil War era and extended to other vulnerable groups, like those who had intellectual disabilities, those who were other non-Black minority populations. And then there was also the perpetuation of eugenics theory. So Dr. William Welch, who was the first dean of the Johns Hopkins School of Medicine and the founding dean of the School of Hygiene and Public Health, really promoted the scholarship of eugenics both nationally and internationally. And so eugenics was the quote unquote science of improving the human population by controlled breeding to increase the occurrence of desirable heritable characteristics. This was actually the foundational elements that inspired the German Nazi movement, it was taught here in the United States. So it favored a Protestant, Anglo-Saxon, and Northern European ancestry. It was the foundation for forced birth control, castration, sterilizations, and euthanasias, really from the early 1890s that really persisted until the mid 1970s. And in addition to Blacks, certain groups that were considered unfit under this eugenics theory were Jews, immigrants from Eastern Europe, the Balkans, Italy. So anyone who didn't really fit that Anglo-Saxon, Northern European ancestry. And then there's the Flexner report in 1910. So this is considered, the gold standard, eliminated medical school as proprietary school across the US, supported the establishment of the biomedical model as a gold standard for medical training. So those of us on this call who are physicians, this is a model we trained under a medical school. But it had racial implications because any medical school that could not live up to those standards were closed across the United States. But what that meant for medical schools that were training future Black physicians, that out of the 7 medical schools that were training Black physicians at the time, the only 2 that were left after those forced closings were Howard Medical School and Meharry Medical College. And this was at a time where African Americans were excluded from predominantly white institutions to receive medical training. So this has contributed to the dearth of really diverse healthcare providers in the US today, and really left Black and other minoritized populations vulnerable to medical abuses in the medical system. So as we think about all this in the context of health disparities and diabetes, this is a fascinating book that I read in 2020. And it's written by Dr. Arlene Marcia Tuckman. She is a historian, a professor of history at Vanderbilt, and wrote this fascinating book on diabetes, a history of race and disease. So I'm going to walk you through how she beautifully lays out how the sort of social order in the US, based on some of the things I just told you, has influenced how we view individuals with diabetes, both in the past and in the present. So initially, diabetes was considered the Jewish malady. It was considered to be more highly prevalent in Jews. It was called Judenkrankheit. And in 1893, there was publications showing a high prevalence of diabetes in certain populations. William Osler from Hopkins and Elliot Joslin recognized what seemed to be a predisposition toward diabetes in the Hebrews, as they called it. And they thought this was related to nutritional access and longstanding oppression stress. So in thinking about this from sort of a behavioral standpoint, as well as a hormonal standpoint, Jews at the time were fleeing Eastern Europe and the poverty and hunger that were a part of that experience. So when they came to the US, they were really were able to have more exposure to more food and more plentiful food. And so that was really, that was thought to be a contributor to the obesity and diabetes. But then there was also this sort of neuroendocrine hypothesis that there were, because they have really undergone such tremendous, like sort of oppressive stress over many generations, that there were the stressors of adaptation that were predisposing them. So they were considered the most nervous of the civilized people, and that increased nervous system activity and heightened adrenaline led to higher insulin resistance and contributed to diabetes. Now, this was challenged in the 1930s, as it was thought this was really related to weight gain and not Jewish race per se. And I think if we think about this today, we would agree. And these hypotheses were largely refuted, that this was strictly a German disease after World War II. But as we think about the evolution of the social order, anthropologists were really beginning to call into question that races were really biological, and really saying that race was a product of culture and not biology. And so, there was sort of, though, with that, there was still this movement to maintain the purity of the American race, which really meant the white race. And so consequently, despite what the anthropologists were saying, there was legislation put into place that restricted immigration. And also there were anti-miscegenation laws. So in other words, like interracial, interethnic marriage was considered against the law. And then the Johnson-Reed Act of 1924 really outlined what populations were considered Caucasian or white. So those were those who were Jewish, Italian, Teutons, which is a Greek derivation, and French Canadians. And the idea is because they could assimilate. So as new groups immigrated here to the United States, they basically wanted to make sure that they were assimilated and considered white and not other, because of the way that the social hierarchy was being created here. So then diabetes became seen as a diabetes of whites, and it was considered a disease of the civilized middle and upper class. So this is a very interesting quote from a journalist in 1936 who wrote that, that basically those with diabetes make a good deal better citizen than average. They are never wasters or drunkards, because they have to learn early in their disease to be controlled and self-reliant. They have greater intelligence than the average, and they develop it by constant use. Of course, there undoubtedly have been diabetics with weak character, but they didn't live very long enough to tell the tale. Like, it's kind of interesting how they say that. So basically, with the discovery of insulin, then people could engage in overindulgence. Like, they could pretty much eat what they wanted because it could be treated with the insulin. Now, remember I mentioned that eugenics theory was alive and well here. So you might have thought, oh goodness, having diabetes would be considered part of a defective gene. But because this was believed to be a disease of higher intelligent, upper to middle to upper class whites, then diabetes was sort of given a pass, if you will. And people with diabetes were allowed to continue reproducing, because again, this is thought to be a disease of the highly intelligent. In the interwar years, this was still considered to be a clean disease of whites. And then, and even Joslin sort of summarized the good versus the bad diabetes patient, that if individuals had poor glycemic control and complications, it was due to a personal failure on their part and a lack of moral character. And that'll have implications later on. So again, it's putting the onus of it on the individual and not the environment per se. But then despite, that this is a disease of the white upper middle class, there was a transition in the mid 1930s to focus on the health of the poor. And in 1935 to 1936, the US Public Health Service released their National Health Survey on Chronic Disease and Disability. And they actually saw that chronic disease burden really was more so in the poor than the well-off, and really regardless of race. So they thought diabetes really rose as poverty rose. And in fact, the earlier reports of diabetes that I mentioned didn't really address poor whites or people of color. So this link between diabetes and wealth began to be questioned based on this report that they published. So if we think about diabetes in African Americans, there were low rates of diabetes in the early 1900s. And really in 1897, diabetes in the Negro was considered rare. And that's because there was a high death rate from infectious diseases like tuberculosis, syphilis, cholera, yellow fever, and smallpox. There was also very high infant and maternal mortality rates back then. And African Americans, even though they were no longer in slavery, many of them were sharecroppers. They were still engaged in very high physical demanding jobs. So this resulted in an underestimation of the burden of disease because of the high death rates. But then also there was infrequent interaction of African Americans with the medical system. So that was inaccurate reporting of death, and really there wasn't even the accurate collection of race data. And what's really interesting is in our archives at Johns Hopkins, there is a medical grand rounds in the late 1800s, and it was called A Case of Diabetes in the Negro. Like, it was considered so rare in Baltimore that there was a medical grand rounds on it, which today it almost seems fairly absurd, but this was the state of affairs then. So unfortunately, there was an ignoring of the rising rate of diabetes in African Americans through the early 20th century. So the rising rates were first noticed by the Metropolitan Life Insurance Company in cities like New Orleans, Baltimore, and Atlanta. But because this was considered a disease of civilizations, Blacks were not believed to be civilized enough or have a highly sensitive enough nervous system that they would be at risk for diabetes. So they were believed to have racial immunity from diabetes because they were believed to be a more primitive race. And in addition, the rising rates of diabetes in middle-class Blacks, who actually have more access to nutrition and the like, were largely ignored. There were, though, physicians and researchers who were actually beginning to see that was a false reality. And physicians at Emory and Johns Hopkins noticed that diabetes incidence rates were actually similar in Blacks and whites. And that they experienced similar rates of complications, but that death rates were higher in Blacks, especially Black women. And this was actually corroborated in Dr. Joslin's 6th edition of the treatment of diabetes mellitus. So, epidemiologists were really beginning to challenge that. And Dr. Benjamin Jablons, who was the head of the Physicians Division of the American Jewish Congress, stated that diabetes was not a racial disease, but it was due to improvement in economic conditions and food excess, regardless of race. There were also a group of African-American physicians who really set out to show that diabetes was no respecter of persons, and that the high hustle and bustle that many African-Americans were experiencing as they migrated from the South up to the cities of the North, that they could be as nervous as any others in society, that they could adapt again in that Black middle class. But despite all of this, post-war World War II, diabetes was still considered a disease of whites. And really the diabetes and the disabilities as a result of diabetes complications in Blacks would really remain invisible until the Heckler Report in the 1980s. So I also want to talk about, she talks about diabetes in Native Americans, and it was a very similar, very parallel story. So in the early 1900s, there were low rates of diabetes in Native Americans. Again, diabetes was considered rare in them because they weren't considered as civilized of a population. Similar to African Americans, they were still dying of infectious disease with a short life expectancy. And then there were centuries of federal policies that destroyed the land, the lifestyle, and the livelihoods that had really kept the population healthy. And many of Native Americans avoided hospitals or lived in dispersed conditions where access to medical care, was not easy. So again, what was happening in their community was not really documented. But in the 1950s and 1960s, there was a note of the rising rates of diabetes in Native Americans. And much of this was due to the drying up of the Gila River, and that prevented the trading of farmed goods with white settlers. So as there was a westward expansion in the United States, in order to irrigate the land out there, there were irrigation systems set up, and it really resulted in the drying up of this prime resource, which Native Americans grow their own food, which was healthy. That stimulated their economy because they could trade with others. So as that happened and their land was no longer fruitful, they had to rely on government subsidies and reservations with poor conditions. And again, so what was argued is, well, the reason that they have diabetes is they're a primitive people who are unequipped to adapt to the challenges of civilization. And the US Public Health Service began studying them. Many of us are familiar with these studies, focusing on the genetics of this remaining primitive population that was less evolved. So in 1954, the Indian Health Service was transferred from the Bureau of Indian Affairs to the US Public Health Service, which was better resourced. And then the Acmel Odom and Pima Indians were studied in Arizona. Again, many of us are familiar with those studies. There was a debate about diabetes, the high diabetes prevalence and incidence being due to environment and not to race. So there were sort of two schools of thought. So Dr. Elliott, felt this is really an environmental issue in Native Americans and not race. But then Dr. Bertram Krause was arguing, no, it really is race and genetics. So this was a debate for a long time. But the importance of lifestyle and diabetes prevalence and incidence, really should have been recognized by one really critical observation. So the Athabascan Indians of Southwest Arizona and Alaska Eskimos had unusually low rates of diabetes. And this was despite the fact that they lived in completely different regions of the US. And what was common for them is that they had active lifestyles and they had diets heavy in protein with moderate fat and low carbohydrate. So this should have really solidified the conclusion this is environment and not race. But again, because all Native Americans continue to be lumped together, this sort of distinction was not fully appreciated at the time. So then if we summarize and think about the evolution of the face of diabetes and its disparities over about a 100-year period, this started out as considered to be primarily a disease impacting the Jewish community due to nutritional access, oppressive stress, and sort of being the most nervous of the civilized populations. Then it was considered to be a disease of whites. So due to nutritional excess and overindulgence, it was a disease of the highly intelligent middle and upper class and a disease of the civilized. As it became to be seen as a disease of Blacks, it was really then began to be seen as a disease of poor minoritized communities in urban setting who lacked intelligence and were less civilized. And then again, similarly in Native Americans, because they were primitive, they failed to adapt to Western civilization. And it was really this thrifty gene hypothesis that was predisposing them to diabetes. So if we sort of put all of that together in the sort of the medical and historical context, these sort of have resulted in residual healthcare provider bias toward minoritized patients with diabetes. The trust of minoritized communities have been violated by the medical establishment through all the experimentation and the eugenics theory and all the things I mentioned previously. And there have also been language and communication barriers. So that's led not only to poor access to care, but decreased quality of care and decreased participatory decision-making and engagement in clinical care. And I just want to say a little bit more about the bias, the healthcare provider bias, and not just individual bias, but systemic bias as well. And what we really see is that diabetes, as it became to be seen as a disease of the poor, the less intelligent, the less likely to be cooperative, when it was no longer primarily a white and middle class disease, then there were clinics, sort of clinics that were understaffed, where medical students were then used to perform exams in those understaffed clinics. So this perpetuated the sort of experimentation mindset in minoritized communities. There were negative attitudes toward recipients of Medicaid. I would say that that bias still exists in our system today. And then there was a thought that, well, you know, these poor folks with diabetes really need professionals to guide their diabetes management because they lack the intelligence to do so. These biases persist in the medical system today. And even when patients have comparable degrees of education, if they're different races, Black patients are still perceived to be less intelligent than whites. And so again, these are the unconscious biases that still exist. So physicians exhibit the same implicit biases as the general population. They have a preference for those who are young, thin, rich, heterosexual, and white. Physicians generally do not report explicit race bias, but the impact of implicit bias on physician decision-making is what's important. So for decisions that are based on objective findings, like a urinary tract infection, hypertension with a blood pressure cutoff, there's no overall impact of race bias. But when there's subjective decisions, and pain management is the most poignant example, there is evidence of implicit bias. So essentially, you know, I've mentioned that a lot of the experimentation in slavery was done without anesthesia. And there is still this theory floating around that, well, you know, Black individuals, they have thicker skin, they can have a higher pain threshold. So when there's justifiable reasons to have pain, like a sickle cell crisis, surgery, it is not uncommon that Black patients' pain is inadequately controlled compared to white. So again, that subjective component of decision-making. We also know that patient-physician communication is most adversely affected when there's greater implicit bias. And again, as I mentioned earlier, if you control for actual education, physicians still rate Black patients as less educated than comparable whites. So that's the medical context. I want to shift for a few minutes and talk about the historical context, because I think this all leads into what our solutions need to be. So one of the things that happened is there was changing the diabetes narrative as the face of diabetes evolved. And there were Native American and African American activists who began to challenge, again, this race notion. So Native American activists tied colonialism to the rising diabetes rates and rejected this primitive and civilized notion, and began to publish about the impact of the drying up of the Gila River and the diversion by the white settlers. One of the primary advocates was Peter McDonald, who was the chair of the Navajo tribe in the 1970s. And he cited water shortage, substandard housing, lack of refrigeration, and unhealthy food as contributors to diabetes. And Dr. Taylor McKenzie, who was the first Navajo medical school graduate in the US, really pushed for Indian Healthcare Improvement Act of 1976. Similarly, there were African-American physician activists who challenged the same notions. Dr. Richard Allen Williams, who was the assistant director of the Martin Luther King Jr. General Hospital in Watts, wrote a textbook on Black-related diseases. And Dr. M. Alfred Haynes, who was an epidemiologist, wrote a report on the gaps in the health status between Blacks and whites in America, again, pointing to that this isn't just race, but there are these other contextual factors. In addition, in 1965, so I mentioned the Johnson-Reed Act really, there was sort of around that same time in the 1920s, basically immigration ban to the US. In 1965, that was lifted, and there was the Immigration and Nationality Act, and Mexican Americans then began to immigrate to the US. There were higher rates of obesity and diabetes. They had higher rates of diabetes and obesity than whites in the same neighborhood. That was attributed to their Native American ancestry. So again, this thrifty gene concept applied. This created challenges in them feeling like they were fully accepted as American. And again, they applied this to other Hispanic populations as well, even though they were coming from different places. In addition, Mexican Americans were concerned with having greater access to health services, but importantly, having bilingual materials and providers so that they could fully engage in their health care. There was also an Asian immigration to the US, particularly from Japan, where it was noted that there was increased diabetes following migration to the US, but this was really due to a change in diet and physical activity. And it's interesting, there was a inflection point in the 1950s where there was a progression from Japanese Americans being engaged as migrant laborers in poor economic conditions to improve standards of living. So diabetes in Japanese Americans were viewed as a sign of successful assimilation. However, they challenged this because it failed to acknowledge that there was inadequate nutrition in certain subgroups, and there continued to be discrimination in housing, job advancement, medical attention, as well as the stress and the strain from the internment years in World War II. So then if we sort of put all of these concepts together, there was racial residential segregation due to the way that our policies handled housing. So in the Black community, as African Americans were immigrating from the South up further north to look for other opportunities, as they would move into a neighborhood that was all white, there would be what's called a white flight, and whites would move to a different neighborhood in the city. And to really convert that to a minoritized neighborhood, predatory loan sharks would give loans that had a high likelihood of default. So once there were multiple defaults in a particular neighborhood on loans, there would literally be a red line drawn around it on a map. And unfortunately in Baltimore, we were like leaders in this area. And so that redlining meant that once a neighborhood was redlined, there was a lack of investment to maintain the schools, the public works, or other economic investment in those neighborhoods. In addition, in the Native American community, there was residential racial segregation that really was the result of the Homestead Act of 1862 and the Desert Land Act of 1877, resulting in them really relying on living on reservations and government subsidies. So again, this residential racial segregation then results in not only inadequate sort of contextual factors, but inadequate access to healthcare, discrimination and access to high quality jobs that give good health insurance. And in fact, farm and domestic laborers were excluded from the Social Security benefits of the New Deal legislation after World War II. And if you think about it, those are the kinds of jobs that many minoritized communities were engaged in. My grandmother, for example, was a domestic worker when she came up to the DC area from Virginia. So if we look at this, in addition, federal housing loans were refused to millions of not only Blacks in the US, but Asian, Hispanic, Jewish, and immigrant families. And that didn't end until 1968, after Martin Luther King Jr. was assassinated. And so again, this is a very recent, that was the last of the Civil Rights Act. So the Fair Housing Act was signed into law in 1968. That's when the federal housing discrimination loans ended. So unfortunately, because of those systemic policies and factors, the structural and institutional racism have left us with neighborhoods that have poor stability and cleanliness, very few sidewalks, open spaces, and green parks to engage in physical activity, a lack of access to healthy food, and a lack of access to affordable housing. So this is sort of showing in in our region of Baltimore, a typical corner store, which really doesn't have healthy foods, and the Indian trading post out southwest, again, without access to healthy food. So it's no wonder that certain communities have a higher prevalence of risk factors for diabetes and ultimately have higher rates of diabetes and obesity and disparate outcomes and once they get the disease. So if we think about the postmortem of the Heckler report, the recommendations really focused on lifestyle choices and behaviors, but it didn't focus on the need to further desegregate medical institutions, to improve access to quality health care, or increase investments in preventive medicine. The focus was really on interventions to change the behavior or not the condition. So, remember Jocelyn said, well, golly, this is probably poor moral character that people get complications of diabetes. But that's, again, blaming it on that, putting the onus on the individual, but not addressing the environment in which that individual lives and often doesn't have a choice in. And the report also failed to discuss the plight of poor whites and the role of socioeconomic disadvantage in diabetes risk. So there are areas of the US, particularly Appalachia, where the rates of diabetes and the complications among poor whites are just as challenging. So again, that was not addressed in the Heckler report at all. So in the last few minutes, I want to talk about, so knowing all of this, what can we do? What can we do individually, and then what can we do as a system? So one of the first things we can do is work on breaking the bias habit and becoming an ally for minoritized patients and communities. So at Hopkins, we've partnered with Dr. Molly Carnes on her intervention. Is called BREM, Bias Reduction in Internal Medicine. And she studied this previously at the University of Wisconsin, where this is a 3-hour workshop that addresses not only the contributions to bias, but bias mitigation strategies. And in her study, she had randomized 46 departments to get the intervention, and there were 46 control departments. And in the intervention departments, after 3 months after, there was increased awareness, motivation, self-efficacy, and action for engaging in gender equity promoting activities. The first version of her intervention focused on gender bias. And they also reported a more positive departmental climate. But I think what's really compelling in her study was that the intervention departments had greater diversity and new hires 2 to 3 years after they had received the intervention. So this was a more sustained effect. So we've actually, this is the foundation that we use for all of our unconscious bias training across Johns Hopkins Medicine. And what the strategies are to recognize, label, and challenge stereotypes when you see them. If someone's about to say all people of a group are, whatever is about to come out of your mouth, positive or negative, is a stereotype. So we have to be careful. Consider the opposite. Instead of assuming all people in a particular group are a particular way, consider the opposite and use data to inform those decisions. Identify counter stereotypical exemplars. So if there's someone from a group that you have a bias toward, really getting to know someone in that group who you admire for other reasons that have nothing to do with their socio-demographic characteristics can enable you to see the whole group differently. You also want to individuate and perceive variability. So, making sure that you're not lumping, again, all people together. And then practice common identity formation. So what is something that you have in common with that individual? Again, outside of the socio-demographic characteristics. So most of us will find we have a lot of things in common. I'm a Terrapin, that's where I went to college. I went to UVA for medical school. So as soon as I find somebody from one of those two places, that's an immediate connection. And then you want to practice perspective taking. So just think about what it's like to have people question your competence, question whether you have the financial means. What is that like for certain people to have to walk through society dealing with that constantly? And then finally, reciting a growth mindset and internal motivation messages, not saying, oh, we all have biases, there's nothing I can do about it, but intentionally, this is something I want to work on, just like we would do breaking a smoking habit, for example. So that's the individual. I want to spend the rest of the time talking about sort of systemic solutions. How do we infuse health equity principles into our clinical workflows? So we have been very focused on teaching and using the culturally linguistically appropriate standards to guide our equity work at Johns Hopkins Medicine. These standards were put out about 20 years ago by the Office of Minority Health. The principal standard is that you really want to focus on providing effective, equitable, understandable, and respectful quality of care and services that are responsive to the diverse cultural and health beliefs and practices, the preferred languages, the health literacy, and any other communication needs that your catchment population has. And if we really think about that, language and literacy support is so critical. This has been so critical during COVID, for example, but it's offering language assistance to individuals who have limited English proficiency or other communication needs, informing all individuals about the availability of those, and asking what is their preferred language for healthcare. Also ensuring the competence of individuals providing the language assistance. It is illegal in most places to have a family member interpreting for a medical visit. And in fact, you need to be a qualified medical interpreter, even if you're doing it in the medical system. So our language services department at Hopkins oversees all of those efforts. And then you want to make sure you're providing easy to understand print and multimedia materials and signage and languages commonly used by the populations, again, in your service area. And I don't know how it is at Einstein, but we like to do these very long, laborious emails out to everybody about everything. And, really, like, we've been sort of really having our marketing and communication focus on the literacy level and the main points, and can we use infographics to make sure that we're reaching our patients and they understand. And then there's also an education, governance, and data decision-making aspect to the class standards. So it's really important to educate and train our governance, leadership, and workforce in culturally and linguistically appropriate appropriate practices. So we are starting to incorporate these principles into our annual staff update, and then also collect and maintain accurate and reliable demographic data so we can actually monitor, on the outcomes, both quality outcomes, population health outcomes by demographic groups to really inform our health equity interventions in our service area. And if we think about what are interventions that have been shown to be effective, Dr. Felicia Hill-Briggs, who was formerly a faculty member at Hopkins, but is now Vice President for Prevention at Northwell Health, wrote a really phenomenal piece on social determinants of health and diabetes earlier this year that was published in Diabetes Care. And she's a past president of healthcare and education for the ADA. And so just focusing on what they did is they summarized what are social determinants of health-focused interventions that have been shown to improve outcomes in diabetes. So if we look at access, affordability, and quality of care, the Affordable Care Act increased insurance coverage for adults with diabetes, particularly white, Black, Hispanic, with low income and low educational attainment. That increased access to diabetes care as well as increased diabetes detection. And there was a decrease in cost-related non-adherence in states that underwent Medicaid expansion. Another access intervention using community health workers, those have been shown to result in better diabetes knowledge and self-care behaviors, improved glycemic control in underserved African Americans and Hispanic communities. So again, effective intervention improving access. If we think about affordability, interventions that teach self-management interventions delivered directly to underserved populations have resulted in decreased hemoglobin A1C and blood pressure. And then looking at quality of care, interventions to improve quality of care that use health IT interventions to guide providers toward evidence-based practices have been shown to improve quality of diabetes care among race and ethnic minorities. So we know that in diabetes, successful interventions that improve health disparities have to target all levels, so the patient level, the provider level, and otherwise you can't just do one, it's typically multifactorial. And then interventions aimed at the microsystem or healthcare organizational level, again, have been shown to improve diabetes outcomes. So this is when you're thinking about registries, integrating practice guidelines into your IT and ordering systems, as well as care management to help address barriers. And then finally, community and health system intervention. So health systems engaging with community-based organizations and coalition building and advocacy really are important in improving health outcomes and have been shown to reduce race and ethnic disparities in care. The other social determinants of health intervention area where we have evidence in diabetes is in the neighborhood and the built environment. So if we look at interventions to improve housing, the Moving to Opportunity study, which was published in 2011 in the New England Journal of Medicine, randomized about 5,000 families into 3 groups. One group was required to move from a high poverty area to a low poverty area. Second group got a traditional voucher and a control group got no new assistance. And essentially those who moved from a high poverty census tract to a low poverty census tract had a lower prevalence of extreme obesity and diabetes when compared to control. And probably it wasn't just the housing, but the whole environment, the food environment, the physical activity environment, job opportunities all improved. In addition, there was another housing intervention initiative to end chronic homelessness, which not only placed individuals in permanent housing, but also provided them primary and mental health care that resulted in a decreased risk of new onset diabetes. Interventions aimed at the built environment have primarily been policies to improve the walkability and green space infrastructure in cities. That's been shown to improve obesity, which is a strong risk factor for type 2 diabetes. And then finally, food environment interventions. So increasing grocery store presence in low-income neighborhoods has been shown to reduce the prevalence of diabetes. And then having diabetes targeted food and self-management care at food banks has improved not only blood sugar control, but improved nutritional consumption and reduced food insecurity. And then the last intervention I want to talk about is advocacy and policy. So this is where our voices as scientists and clinicians really can be very powerful. So these are all of the movements that really have happened in my lifetime. And I think that, because of the advocacy of various groups, this has enabled us to make advances in so many civil rights that ultimately impact our health outcomes. So we know with the Affordable Care Act, there was increased insurance coverage, expanding access to primary care. There were provisions to prohibit discrimination in healthcare. There was a need to address diversity and cultural competency of the healthcare workforce. There were also guidelines to enhance data collection and research and to strengthen the federal minority health infrastructure by augmenting the authority of the Office of Minority Health. There was also the establishment of offices of minority health within each of the 6 health and human services agencies. And then finally, the redesignation of the National Center on Minority Health and Health Disparities as an NIH institute, which now has its own funding streams and RFAs. So during COVID, it was not just the patients with diabetes, but it was so many minoritized communities in Baltimore and the Washington, D.C. area, which is the catchment area of Johns Hopkins Medicine, that were just suffering disproportionately. And we were very fortunate to partner with our assistant director for state affairs for Johns Hopkins University of Medicine. And she was able to get several of us in front of the minority caucuses in our Maryland House, and we were able to connect with key legislators to help us so we could work with them in crafting health disparities legislation and testifying on behalf of it. And so these are some of the wonderful legislators that we worked with and partnered with. And in the Maryland's last legislative session that ended in April of this year, there were 5 pieces of legislation that were signed into law to address health equity and health disparities in the state of Maryland. So our voices are really, really critical because we've got to go very far upstream if we're really going to really dismantle all of those issues I mentioned earlier. And then I would say it's really important to acknowledge the painful parts of our history. We can't really pretend that things didn't happen. And it's not to say that we somehow, by acknowledging the painful parts of our history, that we're in some way, sort of not acknowledging the good parts. I think we need all of it. And this is a really interesting a statement put out by the American Psychological Association very recently, the end of October, where they apologized to people of color for their role, the field of psychology, and sort of promoting, perpetuating, and failing to challenge racism, racial discrimination, and human hierarchy, because they were very much proponents of the eugenics theory and helped purport some of that. So basically, the APA basically acknowledged that white male leadership contributed to various things. And you can see here, they specifically call out eugenics, which was used to support segregation, sterilization, and anti-marriage laws. And they basically apologized for this and recognized that that those decisions ultimately impacted not only the health and well-being, but the integration of people into society and their view as their view as humans and lives worth valuing. And this really is the last thing. So biomedical workforce diversity is critically important. And so that's why I shifted my career focus 2 years ago to focus on this area along with health equity. We know that right now, less than 12% of the US physician workforce is underrepresented compared to the representation of those groups in the US population and the disparities that exist. And so if we think about the implication of those historically Black medical schools that were closed with the Flexner report, that this study published last year estimated what is the impact if, for example, those 5 medical schools had been given the resources to be able to then live up to the biomedical model, what would have been the impact on the biomedical workforce today? And they estimate that if those 5 medical schools had stayed open, they would have collectively trained an additional 35,000 graduates by 2019. And that would have resulted in a 29% increase in the number of graduating Black physicians in 2019 alone. And I would say not only Black physicians, but other underrepresented groups, because there are many other underrepresented groups that train at historically Black medical schools. And we know that diversity leads to greater scientific impact. It leads to a higher impact in publications. And this study really showed the importance of diversity even in elevating the impact of our science. So this is our roadmap, diversity, health, equity, and inclusion roadmap 2023 at Hopkins, that really is marrying the biomedical workforce diversity with culture change and health equity. And I just want to close by just acknowledging my family, who have really been a source of inspiration. My parents, shown here at their 80th birthday about 6 years ago, and my son Andrew, and then my husband Christopher Golden, who's a neonatologist at Hopkins, and as you can imagine, during the pandemic, when Andrew was home with us for 5 months unexpectedly, there were a lot of fascinating conversations across our table, given everything that was going on. So I've learned as much from my son now, I feel like, as I've taught him. And also, I love this photo with our House Staff Diversity Council. The younger future generation are truly inspirational to me in this work. So I thank you for your attention. I'll stop sharing. I'm happy to take any questions in the remaining time.
Thank you so much, Sherita. This was such an outstanding, highly informative presentation. Thank you. I know your time is limited, but I would love
I'm fine.
to ask for, please, please, I would love for people to ask you questions.
Hi, Sherita. This is Shivani.
Hi, Shivani.
How are you?
I'm good. Shivani, I was Shivani's MPH advisor, like, it seemed like many, many years ago. She's a star in her own right now. So.
Well, you trained me really well. So it's so nice to see you. I'm sorry I don't have my camera on, but I have a 6 toddler on my lap right now.
No problem.
But I did thank you so much for that amazing talk. And really, it was so comprehensive, thinking about all the different levels that we have to, impact to really affect change. I'm wondering, now that we are starting to have these conversations, have you figured out any sort of rigorous kind of training program where we can really instill these aspects of medicine into the younger, generations, so that this can be effective change for generations to come?
Yeah, so one of the things, so we have a Department of History of Medicine at Hopkins. And so the chair of that department, he's the one that actually got me in touch with Arlene Tuckman, who wrote the book that I mentioned. So one of the things that we're doing, we actually, he's actually incorporating, working with our undergraduate medical education group to incorporate some of these historical features into the medical school curriculum. And then also they do, sort of lectures on when should race be used and not used, and sort of how race has been used to maybe bias algorithms. So beginning to really address quite a bit of that. But one of the things that we've noticed, and I'm not sure how it is at Einstein, is that our young generation of like medical students and residents, like the younger generation, they are more familiar with a lot of these concepts than our faculty are. So one of the things that we're working on, and I will say, I'm a Black physician. I did not learn about any of this stuff in medical school. And as I was reading Arlene Tuckman's book and a couple of others, like I would just be like, I would gasp and close it. My husband's like, what are you reading? Like, because it was just so shocking to me that none of this was taught. But the younger generation, they know. So one of the things we're doing is we're developing like an anti-oppression curriculum for our faculty so that everybody can be brought up to speed at the same time. And like last year, we had a structural racism sort of town hall series for our faculty and staff, just so that people can hear about things in a non-threatening way and ask questions. So that's sort of how we're addressing it. So we are addressing it with the undergraduate medical education curriculum, but we also want to make sure we're addressing it with our faculty as well.
Got it. Thank you.
Hi, this is Carmen Isasi. Wonderful presentation.
Thank
I
you.
really appreciate the historical context. And it made me think about like other populations that are also, underserved and historically neglected in medical research and medical healthcare. And in particular, immigrant populations. And you mentioned, Hispanics and how easy the medical system and society tends to attribute things to culture, when in reality it's the longest standing poverty and the lack of resources associated with that. So
Yes.
I wonder if you can comment on that.
No, I completely agree with you. And thank you for that question, because I think one of the things that, one of the things that became clear for us during COVID, we have a large Latino community a little, like we've got sort of, we're in East Baltimore, main Johns Hopkins campus. We have another hospital a little further to the east. So we have a large Latino community, and some were documented and some were undocumented. So during COVID, in order to really deliver healthcare adequately to the community, we had to partner with a trusted community partner. So there was a church in that community called Sacred Heart of Jesus Church that's a trusted messenger. So we set up our COVID-19 testing on the parking lot of that church, and then it got turned into a vaccine delivery site. And as we think about healthcare moving forward, I'm actually convinced that we need to take the healthcare to the community. I don't know how we would fund this, but you know, there need to actually be like really like highly resourced clinical sites that are set up in community-based settings, because I do think for certain communities like our immigrant community, you're right, there are a lot of assumptions that are made. And, you know, I think if we're delivering care in the community, as opposed to them always having to come to us, then I think the eyes of our clinicians will become more open. You know, and I also think the provision of language services is really critical. So, you know, we've been doing a lot of work with our language services team to make sure there is adequate, you know, whether it's in-person, video, remote, various kinds of interpretation services need to be available. So that's a really important point.
There's a question in the chat from Bill Jacobs. Could you comment on your vision for confronting the disparities of healthcare in resource-poor settings? Do we need to be researching cost-effective interventions?
Yes. So the answer to the last question is yes. And then, so this is in poor resource countries. I do think some of the models that have been effective in, you know, some under-resourced areas of the U.S. could be extended to under-resourced countries. I think, you know, when I talk about this kind of work, you know, if I'm talking to an international audience, this is like the U.S. experience, but I think in every country, people can look and probably pick out what have been the policies and practices that have been embedded into that country's like history and fabric that are contributing to health disparities, to then be able to figure out, so then where do we need to be targeting? So I know a lot of my colleagues in infectious diseases, for example, like the community health worker model, it may have a different name in a different country, but that community health worker model is actually very effective. You know, sometimes using text messages can be very effective to help support, you know, patients with follow-up. I mean, what's interesting is we found in many under-resourced areas, people may not have access to a PC or a computer, but they often have access to a smartphone, and being able to, this is again, thinking more innovatively about, you know, how to then relay things via text message. So I know one of my colleagues, for example, infectious diseases, and they were doing a TB treatment program in a part of Africa. And so as a part of the reminder system, they sort of used text messaging, and that was like very effective, right? So I think we have to be creative. I think there's lessons from the US that can be used in other under-resourced countries, because we've got some under-resourced areas in the US too. You know, so I think we need to sort of share in some of that knowledge and the approaches. These aren't easy. These are not easy issues. I mean, as I was reading that book last year, I would get like exhausted at certain points, and I'd have to stop. And I was like, okay, we can't lose hope. We have to be creative. But I think we actually know a lot more than we think we do about what works. We just have to figure out how to implement in different settings. That's the key. So I think you need to spend less time studying and more time like investing in the implementation approach.
Thank you for what you do, and thank you.
Thank you.
And just a quick question, just having finished serving on the National Clinical Care Commission for the last 3 years, where we examined the status of diabetes care in the US at the present time, there was absolutely no question that as you would all imagine, absolutely no question that the major issue was health disparities beyond everything else. Now, I faced some opposition in trying to propose that be the number one issue, that we would propose to Congress, because it was said to me by one individual that certain interventions that have been intended to improve health disparities don't always succeed, or perhaps divert resources elsewhere. I was very surprised to hear that. And I feel, Sherita, you have much more background to be able to answer that.
Mhm. Yeah, I mean, so that's an interesting perspective. That comes up a lot. And one of the things that we have been trying to tell everyone is all the boats rise together. So if you actually make society and the healthcare system work for the most disadvantaged, then it's going to work for everybody. You know, it's sort of like, even as we think about disabilities and universal design, if you think about it, you know, I remember, you know, as a little girl when they first started, and some of you who have as much gray hair as I do or more are going to remember when they started putting the lifts on buses. Like, that was a big deal for somebody with a wheelchair to be able to get on the bus. And then when they actually did the sidewalk with the little, like the dip in the sidewalk on the curb, like that was huge. Because I was like, golly, like when my son was little and I had a stroller, like that helped me too. Right. So the thing is, and I thought about this the other day, because like my mom has Parkinson's and we went somewhere in a wheelchair and like that curb did not have that. And my father and I were like, you know, like, what are we supposed to do? We figured it out. But the point is that benefited so many other people in addition to those who are in a wheelchair or a walker. So but there is still a lot of pushback. I mean, we even get that in the biomedical workforce diversity. Well, if we let too many of them in, then, you know, it's going to take away from, you know, the white males getting in. It's not. It's like all the boats are going to rise. Like, it's not. So but that really takes a lot of deep forethought, and there are people that aren't there yet. So I think we just have to keep explaining that, you know, design for the most underserved is going to make the boats rise for everybody's going to benefit. So I think that, and people are very afraid. I think people think if, you know, there's not enough resources or thought to go around to everyone when there actually is. So we just got to keep, and God bless you, Meredith, for at least even bringing it up, because, you know, you probably prick someone's conscience. So the next time that they're in an environment, they might be more likely to think about that. So we have to speak up like you did.
Well, thank you, Sherita. Now, does anyone else have any questions? It's just such an incredibly important topic, and Sherita, you handled it with such depth and breadth, and it was outstanding. And any other questions before we close?
I just want to say hi to like Jill and Rita and Judy and Robin. In fact, so Nary's. I see so many of my friends on here that I haven't been able to see you all in person.
Hi, Sherita. I'm recovering from the flu, so I don't have much.
Oh no!
I really
I'm
enjoyed
sorry.
your talk. Thanks.
Thank you. I saw Carlos on earlier. He probably had to go and like save somebody's heart, but but it's great to see you all. Thanks for having me.
Oh, one quick